Hello everyone. Today's topic is infantile esotropia. So starting with epidemiology, 1 in 403 live births to as high as 1 in 50 live births, depending on different studies and depending on different resources and different communities. Regarding the genetics, it is a multifactorial disease. There is no specific gene. But Dr. Marshall Parks noted primary monofixation syndrome occurs 11 times more frequently in first-degree relatives of infantile esotropia patients. Also, prematurity and low birth weight associated with increased risk of infantile esotropia. So regarding infantile esotropia etiology, we have three theories. The first one, the nature and Worth said that there is a congenital defect in fusion center in those patients, so they are born with no fusion. And whatever we will do for them, they will not regain fusion or stereopsis. On the other hand, we have the nurture theory by Chavez, who postulated that it is the effect of eye misalignment that impairs patients' ability for fusion with time. And we have the combination of both theories, and it's more accepted. And it said stereopsis emerges abruptly in the first few months, but degenerates within few months of uncorrected esotropia. Infantile esotropia, the clinical features: neurologically normal infants and equal visual acuity with amblyopia in less than half of the patients, and large constant esotropia, more than 30 prism diopters, low hyperopia +1 to +3 diopters in most of the cases, but we have patients with infantile esotropia who are myopic even, and dissociated vertical deviation in 57% of the patients, inferior oblique overaction in 78% of the patients, but both DVD and inferior oblique overaction usually will happen later, maybe at the age of 3 years or more. Also, latent nystagmus will happen later. And monocular smooth pursuit asymmetry, nasal to temporal asymmetry when we are using OKN drum on those patients. So here we are demonstrating the cross-fixation. And here when the patient is looking on the right gaze, he is using the left eye, and that will lead to pseudo abduction deficit in the right eye. On the other side, when the patient is looking on the left gaze, he will use the right eye, and the left eye will not move. So that again will give a false impression that this patient is having abduction deficit. So how to make sure whether it is really abduction deficit or it is pseudo abduction deficit? We occlude this eye and move the target to that side, and this eye will move normally if there is no abduction deficit in this child. Another thing that can help us, if this does not work, to do patch test for one of the eyes for 30 minutes, and then again test the extraocular motility, and we will find normal abduction in those patients or near normal abduction in patients with infantile esotropia. That is a very important sign, because if the patient is having abduction deficit -3 or -4, that will lead us to another diagnosis, whether 6 nerve palsy, Duane retraction syndrome, or other restrictive entities of esotropia. Inferior oblique overaction, in that child, we will find here hyper deviation on adduction. So here it is around +1 inferior oblique overaction in the left eye, and here we have more inferior oblique overaction, +2 to +3 inferior oblique overaction in the right eye. And here is the grading system for the inferior oblique overaction. Usually we compare the inferior limbus level in this eye comparing to this eye, and that is how we are grading the inferior oblique overaction. Dissociated vertical deviation, it could be manifest, it could be latent, and mostly it is latent in most patients, and in few patients, especially if there is amblyopia, patient will develop also manifest DVD in one of the eyes. So here when we are using the Spellman occluder, the translucent occluder, we can figure out that the eye is going up, out with extorsion. So DVD have three components: hyperdeviation, exodeviation with extorsion. So that will happen when we are doing prolonged occlusion for one of the eyes. Usually occlusion here you need to do it for a few seconds, so you will be able to elicit that dissociated vertical deviation. Coming here to the latent nystagmus.
There are no oscillations. When one eye is occluded, binocular oscillations are seen jerk away from the eye that's occluded. Note here, the right eye is occluded, the jerks are away from the occluded eye. And again, away from the left eye, which is occluded.
So simply regarding the latent nystagmus, whenever you are patching the right eye, the patient will have left jerky nystagmus. Whenever you are patching the left eye, the patient will have right jerky nystagmus. So the direction of the jerk nystagmus will be the same as the eye which is fixating. So if you close the left eye, you will have right jerky nystagmus in the right eye. If you close the right eye, you will have left jerky nystagmus in the left eye. Coming to differential diagnosis of infantile esotropia, early accommodative esotropia, that usually will happen after the age of 6 months. It's usually intermittent esotropia in the beginning, and hyperopia will be more than 3 diopters, and the management will be glasses. Duane retraction syndrome, esotropic Duane retraction syndrome, those patients definitely will have marked limited abduction with a small angle esotropia, anomalous head position, concomitant ET with palpebral fissure narrowing with adduction, presence of upshoot and downshoot. Congenital fibrosis of extraocular muscles, those patients will have poor ductions in all directions with upgaze deficit and ptosis. Sensory esotropia, patients with poor vision, organic cause will be there, whether cataract, retinoblastoma, optic disc hypoplasia, or retinal dystrophies like Leber congenital amaurosis, and that will lead us to the importance of having full examination on any patient with strabismus. We need to do full examination, anterior segment, posterior segment, along with psychoplegic refraction to reach the proper diagnosis. Sixth nerve palsy, abduction deficit with esotropia in the affected eye, and nystagmus blockage syndrome. Usually those patients will have moderate to large amounts of manifest nystagmus, orthoptic when inattentive, and variable ET and mild nystagmus when they are attentive. So nystagmus blockage syndrome patient will converge the eyes to dampen the nystagmus. So whenever the patient is inattentive, he will be orthotropic with nystagmus, and whenever he is attentive, he will converge his eyes to dampen the nystagmus, so he will have or she will have variable esotropia with mild nystagmus. Also, observing patient for pupillary constriction during esotropia will help you in diagnosing nystagmus blockage syndrome. Coming to the management, correction of refractive error, if we have hyperopia more than or equal plus 2.5 diopters, or if the patient is having anisometropia of 1 plus 1.5 diopters or more, in such cases we usually start by giving the glasses and then re-evaluate the patient after 4 to 6 weeks. Also, amblyopia treatment is extremely important before any surgical intervention. So in patients with strong fixation preference, we start doing patching for the preferred eye, and we will do the surgery once the patient is having alternate fixation. So for example, if a patient coming to you to the clinic with right constant esotropia, whenever you occlude the left eye, patient will take fixation with the right eye, but once you uncover the left eye, patient will have unmaintained fixation in the right eye. That means the patient is having right eye amblyopia. So you should start with doing left eye occlusion therapy, amblyopia therapy, and follow the patient 2 months, 3 months until the patient is having alternating fixation, or at least he is maintaining fixation in both eyes. Medical therapy, botulinum toxin, it can be used as an alternative in a case of small to moderate angle esotropia. Also, it can be used as an adjunct to augment the effect of surgery in a patient with large angle esotropia. For example, for a patient who is esotropia 60 or 70 esotropia, rather than doing 3 muscle surgery, I can do bilateral medial rectus recession and augment the effect of my surgery using botulinum toxin intraoperatively. Surgical options, we have bilateral medial rectus recession. That is usually the initial surgery for infantile esotropia patients. We can do unilateral MR recession with LR resection in patients with severe amblyopia after doing all the efforts to treat the amblyopia. And timing of surgery, we have 3 schools or 3 approaches. The very early approach usually operate 2 to 6 months of age, and early approach 6 to 24 months of age before the age of 2 years, and late approach after 2 years. The most acceptable is the early approach. Why? Because in that time frame, you can be sure that you have a stable deviation. You can at least repeat the cycloplegic refraction twice, and you can also be able to do alternate prism cover test to be sure about your angle of deviation. And also, if there is coexisting amblyopia, you will start doing the amblyopia therapy before touching the eyes. That is the nomogram for infantile esotropia. So usually anything less than 60 prism diopter, we usually operate only on 2 eyes, and that will be enough to correct the esotropia. If the patient is having 60 prism diopter or more, then we will need to operate on 3 muscles. And in infantile esotropia, usually we do bilateral medial rectus recession. We measure the amount of recession from the limbus. So that will be more accurate, and it will give us more consistent results. For example, if the patient is having 40 prism diopter esotropia, if the patient is less than 1 year, then I will do 10 millimeter recession from the limbus. That is around 4.5 millimeter, and 10.5 millimeter if the patient is more than 1 year old. So that is around 5 millimeter recession in both eyes. For lateral rectus resection, we usually measure from the lateral rectus insertion. So for example, if a patient with 70 prism diopter esotropia, we will do, and the patient is more than 1 year, we will do 10.5 millimeter recession in both eyes with unilateral lateral rectus resection 5 millimeter in one of the eyes. Complications, undercorrections, infantile esotropia more likely to have residual esotropias, most reoperations for undercorrections. Overcorrections also might happen. Early surgical overcorrection should raise concern for slipped muscle. If you did, for example, BMR recession 5 millimeters for 40 prism diopter esotropia and postoperative day 1, you find the patient with large exotropia, maybe 30 prism diopter exo or so, and limitation of adduction. So that should raise the concern of muscle slippage, and you should take the patient immediately to the theater to explore and to see what is happening. Other surgical complications in all strabismus surgeries, and you need to be familiar with globe perforation, retinal detachment after globe perforation, cellulitis, endophthalmitis, anterior segment ischemia, low strictus muscle, slipped muscle, conjunctival cyst, pyogenic granuloma, and corneal Dillon, especially in patients that will have strabismus surgery with limbal incision. Coming to two case examples, 1.5-year-old female, systemically free, presented with inward deviation since birth. On examination, she has central steady maintained fixation in both eyes. Alternate prism cover test at near, it was esotropia, 40 prism diopter, full extraocular motility, anterior and posterior segment examination within normal limits. Cycloplegic refraction repeated twice, and in the 2 times it was +1 diopter, which is not significant. Impression, infantile esotropia with central steady maintained fixation in both eyes. So the plan here was doing bilateral medial rectus recession 10.5 millimeter from the limbus. And that is the picture of the patient before and after the surgical correction. Case number 2, 15-month-old female, systemically free, presented with inward deviation since the age of 1 month. On examination, CSM OU and positive cross-fixation, and the presence of cross-fixation usually also will give me the hint that this patient is having equal vision mostly in both eyes. And alternate prism cover test at near showed 80 prism diopter esotropia, large angle esotropia. Full extraocular motility, anterior posterior segment examination was within normal limits. Cycloplegic refraction done twice, and it revealed only +1.5 diopter, which is insignificant. Impression, large infantile esotropia, and the plan here doing bilateral medial rectus recession 6 millimeters with right eye lateral rectus resection 6 millimeters. I hope this small lecture was beneficial, and thank you so much.